Great, thank you very much. I hope everyone had a nice break, and very much looking forward to the rest of our time together. It's been a great discussion thus far, and I'm happy to lend some thoughts on the cardiovascular kidney metabolic syndrome. I think I'll try and pull together many of the themes that the other speakers have already brought up, and I think this is a chance for us to consolidate some key topics, some key understandings, and also identify some future areas that will be very relevant for us as we manage our patients. Can I advance with this? So here's sort of what I want to cover in the next 50 minutes or so. Review the pathobiology and epidemiology of cardiovascular kidney metabolic syndrome. I think Dr. Hani gave a terrific introduction to many of the principles already, and I hope to maybe consolidate some of the key elements there. And then we'll do a very, I think, comprehensive but focused review of very seminal clinical trials results, again, from a cardiovascular perspective, so you'll have to forgive me if I take some license there. This is obviously the Obesity Symposium, and so this is not new to the audience. Everyone has spoken about this. I think what I want to focus on is the far right-hand part of this slide, which really illustrates many of the obesity-related comorbidities. And as you kind of scan down that list, again, the other speakers have talked about many of these: type 2 diabetes, thrombotic complications, cardiovascular diseases of all different manifestations: stroke, dyslipidemia, hypertension, coronary disease, and heart failure with preserved ejection fraction specifically. And I think one of the concepts that we have to get through is not to think about these as necessarily different diseases, but part of the same pathobiology. So you heard already a little bit about this, but the American Heart Association thought it was so important, given the prevalence, the epidemiology, the burden of the diseases, and then the convergence of a lot of these from a clinical and population health standpoint, that they actually put out this statement. So this was a statement commissioned by the American Heart Association on the cardiovascular kidney metabolic syndrome. And so I want to take you inside that document for just a few minutes, and I think we'll use this to then have a little bit of a wide-angle lens on not obesity per se. You've heard from Neda, you've heard from many of the other speakers about treatment of obesity and what happens to weight loss with many of these very powerful therapies that we have, but I want to take a slightly wide-angle lens to say what else is happening with these therapies from a cardiovascular, kidney, and metabolic standpoint. So first, just the definition, and I think the relevant part I've tried to bold here, but what do we mean when we talk about CKM syndrome? And I think it's really well stated here that it includes both individuals at risk for cardiovascular disease due to the presence of metabolic risk factors and or chronic kidney disease. That, I think, is a very important part that I will try and emphasize, because I don't think as cardiologists, we certainly don't do a good enough job thinking about CKD, though it's a very powerful risk factor and risk predictor, as well as individuals with existing cardiovascular disease that is potentially related to or complicates metabolic risk factors and or chronic kidney disease. So you've already seen this slide. I think this is a very helpful framework for all of us that are clinically active, because I think it follows the patients that we all take care of every day. Of course, where we want to be is stage 0, no risk factors, really thinking about primordial prevention. I think some of the questions have even raised this concept of primordial prevention. And then stepping across these different stages from left to right, starting, of course, with excess dysfunctional adipose tissue. That winds up being the first lesion for many of the patients that we care for, and then progressing very quickly from stage 1 to stage 2, where you have metabolic risk factors and or chronic kidney disease, then subclinical cardiovascular disease and the CKM syndrome, and then obviously stage 4 too many of the patients that we take care of every day that already have clinical cardiovascular disease and the CKM syndrome. So I think not every patient follows this path sort of from left to right, but I think this is the paradigm that we are all sort of working under. And I think as you heard about the data for UAE, you heard about the global data about epidemiology. In the US, it's striking. The prevalence of obesity is 50% of the population. If you look at obesity and overweight, 70% of the population. And so all of us, I think Dr. Hani said it very, very well, we all, whether we choose or not choose, are going to be CKM providers, CKM clinicians, because these are the diseases that most of the patients have that we are caring for. I think what's quite interesting is not just connecting the dots clinically, but to think that there's a shared pathobiology for many of the diseases and many of the domains of the CKM syndrome. And so if you start at the top here and you think about, sort of excess, and you think about sort of excess dysfunctional adipose tissue, and then in the center here are many of the common pathways and common mechanisms that we think then lead to chronic kidney disease, metabolic diseases, diabetes, and then obviously the cardiovascular diseases. And you can see that this, I think, figure is really meant to talk about a shared pathobiology across the different elements of the CKM syndrome. These are data for the US, and I don't know the exact data obviously for here, but from what we saw, the numbers that we saw this morning, I don't think they're going to be that different here. And so this is actually just looking at the prevalence in the US population of different stages of the CKM syndrome. And if we start at the bottom here, that's age over 65. You can see that stage 0, that's 1.8% of the population over the age of 65 actually is at stage 0, where we want to be. Primordial prevention, no evidence for dysfunctional adipose tissue, no evidence of subclinical or clinical CKM syndrome, or certainly cardiovascular disease. I think what's most striking here is actually at the top part of this table, which is age 20 to 44. And look at the proportion of the population that's stage 0 in the age 20 to 44. It's less than 1 in 5, right? So more than 80% of young people in their 20s, in their 30s, are already somewhere along that CKM syndrome. Most likely that's obesity, insulin resistance. They're already moving down the pathway of cardiovascular disease, chronic kidney disease, diabetes, the overlap and the convergence of all of those things. And we know how that story goes, right? All of us that take care of patients, that used to see patients in their 60s and 70s coming to the cardiac cath lab or coming to the ED with acute coronary syndromes. And now we're seeing that happen in their 40s. We know what's going to happen. We know what is going to happen to this population of patients when we follow them for the next 10, 20, 30 years. And so the time for action is now. I think that having a sense of urgency about what can we do is really front of mind for all of us. And it's also why I think sessions like this, symposiums like this can be so powerful to bring people together to solve big challenges like the ones that we are facing. I think all of us, and again, this is from a cardiovascular lens, but CKM from our lens is this, right? This is what we all know. We might think of these things as individual diseases. Hey, I'm a heart failure doctor. I'm an endocrinologist. I'm a nephrologist. But patients usually don't just have one of those problems. Again, we already talked about shared pathobiology, but look at the shared epidemiology, the shared prevalence. If you just kind of go around clockwise around this figure, up to 45% of patients with heart failure have diabetes. 14% of the population has diabetes. A third of patients with coronary disease have coexistent or concomitant diabetes. And so we might be anchored to, hey, I'm an endocrinologist, I'm a cardiologist, I'm an internist, whatever your area of specialty is. We're all seeing these patients. What the patients want is, if there's shared pathobiology, are there common treatments that can help us make progress? Because otherwise, the fragmentation in the care system actually undermines the care of patients. Because I'm busy being a cardiologist, and I don't want to worry about what's happening to the EGFR, what's happening to the urine protein, but I have to, because that's what my patient deserves. And if we want to make progress, that's a mindset that we have to change and really move in our own care setting. I mean, look at the numbers here are staggering. 3/4 of patients with cardiovascular disease and diabetes have CKD. Up to 44% of patients with diabetes have CKD, and more than 1/3 of patients with heart failure have chronic kidney disease. And so again, this is CKM in action. This is not just science. It's not about a statement, from the Emirates Society or from AHA. These are our patients. This is what we're all doing every day. And so I think, how do we make progress there? What's the evidence that's available to guide decision-making and practice? I think that's a very exciting area for us. I also think it's worth pausing for a minute to say, why is CKM just coming now? Why are we just hearing about this? And again, I think a lot of credit to the Emirates, the collaboration that's happened here between endocrinology and cardiology to talk about CKM. But why are we just talking about this now? Well, I think many of us, if we reflect back on our medical school training, or at least where I trained, I had very traditional organ system-based modules, right? I'm in my endocrine block. I'm now in my cardiology block. And so that very traditional, linear, reductionist approach, right? We think there's, one gene, one disease, and what's the treatment for that problem? And that may have served us well in the past. But when you think about complex pathobiology like this, with multi-organ manifestations of common disease processes, it actually hurts us, because we tend to be fragmented and siloed when the patients want holistic, comprehensive care. I think relatedly, and this thankfully has changed now, there were few, if any, therapies that were investigated for clinical efficacy across multiple organ systems, right? We never had this before because we never had any therapies. And I'm going to show you some of the evidence that has emerged where something that might have been a, quote, diabetes medicine has very powerful effects for renal protection, for cardio protection, for the management of heart failure. We never had that before. And so it just furthered our very fragmented and siloed approach that, hey, I'm over here, these are the medicines I use, these are the problems I manage for these patients, and someone else can do that other stuff. Well, no longer is that the case. I think the way that we do clinical trials, the way that we do evidence generation has also been problematic. We'll come back to that maybe towards the end, and I'm very hopeful that the tide is changing there. Many of the clinical trials, right, we don't want those patients that have advanced CKD in our cardiovascular outcomes trials, right? Because we don't know what's going to happen to them. That's not a population that we're accustomed to following. Same thing in our heart failure patients, right? We don't want the stage 4 CKD patients in our heart failure trials. But that's actually the population that we need better evidence for, to really understand the effect of these therapies. And so the way that we do trials, the way that we evaluate novel therapies has to change. And then I know I've had some really wonderful side discussions as well, that our fragmented model of care delivery and our financing model for healthcare really impede making progress, right? We still don't have a healthcare system that rewards and finances prevention in the way that it does a hospitalization for heart failure, a stent procedure, a bypass surgery, and that's certainly true of the US system. From some of the discussions I've had, that may be true of other systems as well. And so I'm not deluded into thinking that we don't have real challenges that stand in the way of progress, but we also have the tools that are available that are now facilitating a very, very different kind of conversation. And so with that maybe as a backdrop, I want to get into, some of the really important kind of seminal clinical trials that I think are relevant for our CKM patients and the CKM paradigm. And I think these sort of come in a couple different flavors. So one is powerful therapies that have demonstrated significant efficacy along multiple domains of the CKM syndrome, or I think very important clinical phenotypes where there's been very high quality evidence that has emerged. So if we think about ASCVD and diabetes, that's a specific kind of phenotype of patient that deserves to be looked at. Obesity and atherosclerotic cardiovascular disease. We already heard a little bit about the SELECT trial, so I'll review that at the end. And so I want to go through this a little bit quickly and make sure that we're kind of all on the same page. Okay, I might get a little bit into trouble here with the endocrinologist, but this is a cardiologist perspective on, some of this field. So for a disease, right, diabetes, that is defined by an elevation in blood glucose, right? That's the definition of diabetes, and you can do it with certain ways. And is it A1C? Is it a glucose tolerance test? That despite that being the clinical definition of the disease, it's important to remember all of the randomized trials of tight glucose control have never shown a reduction in macrovascular events, have never shown an improvement in mortality. That's not true of microvascular complications. I'm not trying to minimize that, right? Kidney events, eye events, neuropathy, those are all important things for our patients. But to be fair, macrovascular events, mortality has never been improved with tight glucose control. And so against that backdrop, it's no surprise. This is what the management of hyperglycemia looked like in 2018, not that long ago. It was basically everybody's on metformin, and after metformin, do whatever you want, right? It was dealer's choice. You want to use a sulfonylurea, use that. You want to use a DPP-4 inhibitor, use that. You want to use something else, then use. And obviously all of us as practitioners and those that were managing hyperglycemia and diabetes make very sophisticated, refined decisions for their patients based on cost, risk of hypoglycemia, concomitant therapies that they're receiving to try and select the best therapy. But there was no evidence to guide decision-making in this area because nothing was ever shown to be better than anything else. But that whole world has shifted, right? That whole world has evolved. And I think CKM, the CKM story, really is so closely intertwined with what's happened to the patient with diabetes and the management of blood glucose. So I think many people will then remember that going way back 2007, 2008, in the wake of what happened with rosiglitazone, all the concerns about an increase in cardiovascular risk and myocardial infarction, the US Food and Drug Administration put out a guidance to industry saying if you are going to develop glucose-lowering therapies, quote, anti-diabetic therapies to treat type 2 diabetes, you have to do large cardiovascular safety trials to show cardiovascular safety, that there isn't a harm with many of these therapies. And so in response to that, the manufacturers heeded this advice and they said, okay, if the FDA wants us to do large safety trials, that's what we'll do. And so was the birth of a number of important clinical trials, many of which are shown here, not all of them. And from that, I want to just distill out what we learned for patients with mostly atherosclerotic cardiovascular disease and diabetes. So first, for the SGLT2 inhibitors, I've summarized the data of the key trials on this slide. You can see that in patients with atherosclerotic cardiovascular disease and diabetes, 14% reduction in hard cardiovascular events. Remember, that's something that we had never seen before in the era of tight glucose control, versus more liberal glucose control. But now, for the first time, we have a therapy that was tested for safety. Wow, there's a signal not just for safety, but for a benefit, for reduction in hard macrovascular events and macrovascular complications. Even more impressive, the data for heart failure hospitalization. And here you can see many of the elements of the CKM syndrome now coming into clear focus, right? So for these patients that have ASCVD and diabetes, we have a reduction in MACE, we have a reduction in heart failure, almost a 30% relative reduction in heart failure, and the biggest one, a huge 33% reduction in adverse renal events, including a reduction in the need for renal replacement therapy or end-stage kidney disease. Right? That's a paradigm-shifting set of data that emerged because the manufacturers were forced to do cardiovascular safety trials. Right? That's where all this data come from. Otherwise, they would have just done trials that they had done before. We can lower blood glucose and put us on the market, which is what happened many years before that. Similar data for the GLP-1s, right? Again, this is patients mostly with diabetes and atherosclerotic cardiovascular disease, 12% reduction in MACE, a more modest, but still statistically significant reduction in hospitalization for heart failure, and also a more modest, but statistically significant reduction in adverse renal events, and so a true renal protection with the GLP-1s as well. And so now look, I think someone showed maybe the practice guidelines from 2022 earlier. This is the one from 2024. It looks very, very similar. But look at how different this practice guideline looks compared to the one from 2018. It's no longer dealer's choice. Right? Now a patient has diabetes, very prescriptive about using evidence-based therapies that not only reduce hemoglobin A1C, I would add fairly modestly, especially the SGLT2 inhibitors, but have very powerful effects in terms of CKM endpoints. Reductions in MACE events, reductions in heart failure hospitalizations, and renal protection. And obviously similar data, slightly different, some subtleties and some nuances there for the GLP-1s, but I think a very different framework and a very different decision-making process than maybe what we were all accustomed to just a few years ago. So I want to shift gears and go into the heart failure data a little bit. I'm going to move through the early part of this a little more quickly because I think folks are familiar, and then we'll spend a little more time thinking about the HFpEF and obesity data, which is a little bit newer. I know Dr. Hani also talked about this a little bit, and Netta referred to this in one of her cases. So here's the meta-analysis for SGLT2 inhibitors in HFrEF. Remember, this was a class of medicines that was developed as glucose-lowering therapies. Turns out they have a number of other effects, CKM syndrome, highly beneficial for our patients, now being tested in patients with or without diabetes. Right, so all these patients have systolic heart failure. Some of them had diabetes, some of them don't. There's no treatment heterogeneity in those important subgroups of patients. But look at the effect here of the SGLT2 inhibitors in HFrEF. All-cause mortality, cardiovascular death, significant as a standalone endpoint. First hospitalization for heart failure and CV death on the bottom. But I think just as impressive is the final endpoint on here, which was the kidney composite outcome. 38% reduction in kidney composite events. So yes, we should be using SGLT2 inhibitors, all of our patients with systolic heart failure, not just for the cardiovascular benefits, but for the renal benefits that accrue to these patients. And so that's a very different mindset. It's a true CKM paradigm because it's a powerful class of medicines that have effects on multiple different organ systems and multiple different domains. Again, CKD and heart failure and atherosclerotic cardiovascular disease likely have a shared pathobiology. and that dysfunctional adipose tissue and inflammation and oxidative stress might be the pillars of what that common pathobiology is. And here there's a therapy that seems to have beneficial effects along multiple of those axes and multiple of those end organ systems. I think we know these data well. I don't want to, highlight anything in particular here, except to say in our practice for SGLT2 inhibitors, because of the volume depletion issue, we do a 25 to 30% reduction in the loop diuretic dose, when we start an SGLT2 inhibitor. And so, just if you're interested in kind of how we do things, that's been our experience. I think we're all familiar with the guidelines. This is the latest version of the AHA-ACC heart failure guideline, class 1 level of evidence A recommendation. In everybody with systolic heart failure, SGLT2s are recommended, and the final part of the clause is very important, irrespective of the presence of type 2 diabetes. It's a critical recommendation. We should point out, because we're talking about systolic heart failure, the data for the GLP-1s is a little bit of a wrinkle in the story. I think this needs to be explored a little bit further. But if you look at the data that's out there thus far, the signal looks to go slightly in the wrong direction for the GLP-1 receptor agonists in systolic heart failure. Again, I think small trials, small numbers of events, not powered to look at this in any real way. But obviously, this is something FDA is quite interested in as well. I think we had a great discussion earlier about HFpEF. I love this figure. This is from Barry Borlaug at Mayo Clinic, really highlighting that in many ways, HFpEF is the ultimate kind of CKM phenotype, right? We talked about the ASCVD plus diabetes. That phenotype is kind of one emblematic part of the CKM phenotype. But HFpEF, in many ways, is yet another kind of very prototypical phenotype of CKM. And you'll see that one of the most powerful parts of this is the obese cardiometabolic subset, right? We know about that overlap and that overlay. Is a fascinating kind of paper in JACC, just looking at HFpEF clinical trials and the kinds of patients that have been enrolled. And so again, I'm not telling you anything you don't know, because all of you that take care of, quote, HFpEF patients know what's happened to the patients that you've taken care of over the last 10, 15 years. If you look on the bottom right-hand part of this slide, the fine arts data, which was just released at the European Society of Cardiology in London, you can see almost 50% of the patients enrolled in fine arts had diabetes, nearly 50% had concomitant CKD, 50% had atherosclerotic cardiovascular disease, 16% of the patients, so 1 in 6 of the patients enrolled in fine arts had just HFpEF alone without any concomitant CKM diagnosis. Right? That's a vanishing population. They don't exist anymore. They all have atherosclerotic cardiovascular disease. They all have CKD. They all have diabetes, or some overlap, likely multiple of those adjunctive clinical comorbidities. We know the data for the SGLT2 inhibitors, so I don't want to spend a lot of time, on this, but we have seen the same type of very powerful effects of the SGLT2 inhibitors for heart failure with mid-range or preserved ejection fraction. You can see different endpoints here, including all-cause death on the lower right-hand corner, but about 26% reduction in heart failure hospitalizations, 12% reduction in cardiovascular death, again, as a standalone endpoint across the big preserved EF trials, DELIVER and EMPEROR preserved. This is kind of showing, again, across EF strata, the different trials that looked at those subpopulations of patients, and you can see pretty remarkable consistency of effect here with the hazard ratios all kind of lining up in relatively the same area. And so we know this, the ACC put out an expert consensus decision pathway for HFpEF. And they said SGLT2 inhibitors are the cornerstone of therapy for all patients with HFpEF, and rightfully so, right? HFpEF is a CKM syndrome. Everything we've seen about SGLT2 inhibitors thus far, cardioprotective, renoprotective, and obviously glucose lowering and A1C reductions as well. But this is a particularly noxious phenotype, obesity and HFpEF. And so I want to spend a little time, I know Dr. Hani already talked a little bit about STEP-HFpEF and STEP-HFpEF-DM, but I want to quickly kind of go through that with you. So we know that preserved EF is about 50% of all heart failure cases. And of the PEF cases, 80% of those patients have overweight or obesity, plus all the other manifestations that you'd expect. CKD, atherosclerotic cardiovascular disease, diabetes, like we just looked at in the fine arts data. So Mikhail wrote, I think, a very interesting, perspective article in JACC talking about the potential benefits of semaglutide in heart failure with preserved ejection fraction. And in the blue here are effects that might be primarily related to weight loss. And of course, all of those things are likely important: reductions in visceral, pericardial, intramuscular fat, decreasing intracardiac pulmonary pressures. And then in green are all of the other mechanisms that might be at play for these patients. And so in STEP-HFpEF, what was done was, this is, again, phase 2 early study looking not at hard cardiovascular events, but looking at functional outcomes and weight loss as kind of the two dual primary endpoints, and about 530 patients were randomized in the study. And so what you saw here, pretty significant, dramatic improvements in functional status, functional outcomes. You can see the 16.6 for the clinical summary score on the KCCQ with semaglutide relative to placebo. And here's the weight reduction, and Netta nicely kind of went through all of the data for semaglutide and weight loss. And in STEP-HFpEF, it was essentially mirrored, right? About a 13% reduction in body weight with semaglutide, 2.4 milligrams relative to placebo. Then more recently, at ACC 2024, just earlier this year, Mikhail and the STEP-HFpEF-DM investigators reported the data for patients with preserved EF heart failure, obesity, and concomitant type 2 diabetes, right? Again, very prototypical CKM phenotype here, and very similar findings. You can see the KCCQ clinical summary score on the top panel in panel A, and change in body weight in panel B. I think Netta may have already talked about this, but here's kind of a little bit hot off the presses. This is from just last month. Lilly reported in a press release, we haven't seen the full presentation, we certainly haven't seen the publication, I imagine it will be coming very, very soon, that tirzepatide in their heart failure with preserved ejection fraction and obesity study reported significant reductions in the primary endpoint. Again, much more to come. Got to wait for the presentation and the publication, but very important data for tirzepatide now, again, in a very important CKM population, those with preserved EF heart failure, obesity, with or without diabetes. So I want to sort of shift now away from heart failure, now to CKD. And here I think there's also been some interesting data released. And again here, it's with or without diabetes. So interesting sets of data. Before we even get into the data, I do want to make a pitch to all of us around the importance of testing UACR. And I'm looking especially at the cardiologists in the audience, and with a mirror, because I should be taking this advice myself. We don't do enough of this, right? For the patients that we take care of, we don't look at UACR as an important predictor and marker of risk. And we can't wait for the internists and the nephrologists and someone else to do this. We have to be involved in this, because if we're serious about CKM syndrome and managing those domains, those conditions, again, shared pathobiology, different organ manifestations, but if we're serious about managing those patients, then we have to be part of the solution, and that starts with screening. So the data on the left just shows and plots on the x-axis UACR in milligrams per gram, and on the y-axis, the adjusted hazard ratio of cardiovascular death. And you can see it's almost a linear relationship, but the significant increase in CV death starts at about 30 milligrams per gram. And it's almost straight linear after that, right? It's a very powerful predictor of risk. I think the other really important part of the story is that UACR is complementary to eGFR. So there will be many patients who, if we just look at eGFR, which we're all accustomed to, right? Because it comes back on the routine chemistry panel, and we look at the eGFR, and as long as it isn't, there's no red flag there, we don't have to look any further because everything looks good. The problem is patients can go for years and years and years with a, quote, normal eGFR above 60 and be hiding latent chronic kidney disease underneath that would only be detectable if we did a UACR test. And that early diagnosis of CKD on the basis of UACR, not eGFR, has the potential to prevent lots of events for lots of patients. And I'll show you that data in just a couple slides from now. I think we're familiar with the KDIGO ADA heat map here. And so on the vertical, kind of axes and rows are the different eGFR categories. And then across the categories on the top, you can see the different albuminuria categories as well. And so on the left, the A1, if you will, is less than 30 milligrams per gram. So that's what ADA, KDIGO label as normal to mildly increased. But anybody in column 2 or column 3 has CKD, right? And so even across normal ranges of eGFR, those patients need to be treated. So if you look at these patients that have a totally normal eGFR, treat. And this is treat and refer to nephrology. I wonder how many patients we have in our panels right now that have eGFRs of 70, 75, 80, that have latent CKD that's undiagnosed because we don't have a UACR on them, right? It's never been done. No one's ever checked it. I think we should be the ones that check it. We know these data. These are the very, I think, robust data for the SGLT2 inhibitors in CKD. On the left is DAPA-CKD. On the right is EMPA-KIDNEY. These are incredibly powerful effects. So these were patients that have CKD, regardless of the cause. Sometimes it was diabetes, sometimes it was not. Randomized to an SGLT2 inhibitor or placebo. But look at the magnitude of benefit here. So on the primary outcome, it's a 39% relative reduction. Death from any cause, it's a 31% relative reduction. On the left here, you can see the hospitalization for heart failure, right? CKM, what are these patients going to have? What else is happening to them? It's almost a 30% reduction in that event. So DAPA-CKD was also one of the trials that was stopped early because the DSMB said there's no longer equipoise to continue randomization. We have to stop the trial and unblind. On the right, you can see similar data for EMPA-KIDNEY. I think very powerful effects there as well. I think Dr. Hani mentioned the FLOW study before, so very nice to see these data now for Semaglutide in patients with CKD and diabetes across a range of endpoints, right? First major kidney event, kidney-specific component event, death from cardiovascular causes, almost the same exact hazard ratio, 30% relative reduction in CV death, patients that have CKD and diabetes. Reno protection, so the eGFR slope is attenuated. First major cardiovascular event and death from any cause, you can see on panels E and F there. So very nice to see very complementary data for the GLP-1 receptor agonist, just like we saw for the SGLT2 inhibitors. I think there's been one new player, right? We've spent a lot of time talking about SGLT2 inhibitors and rightfully the GLP-1 receptor agonists. I think it's worth then recalling for ourselves that there's been one new player that has come on to the CKM scene as well. That's finerenone on the far right-hand part of this schematic here, which is a non-steroidal mineralocorticoid receptor antagonist. And you can see much more potent for the mineralocorticoid receptor, much more selective, so that should help reduce some of the adverse side effects that we see, especially with spironolactone. You can see the half-life there and relatively modest effect on blood pressure. We all know that Spiro has a pretty dramatic effect on blood pressure. In fact, we use it for resistant hypertension for that purpose. But finerenone has a relatively modest effect on blood pressure. So the two trials that I think are worth mentioning kind of in the CKD context are Fidelio DKD and Figaro DKD. So those were two components of the overall Fidelity program. And they both looked at patients with diabetic kidney disease, right? Patients that have CKD, but also have concomitant diabetes. And so when you put these two trials together, here's what you saw. But here was the interesting thing about Fidelity, right? Again, getting back to the CKM framework, shared pathobiology, multiple manifestations of the same underlying disease and pathobiology, is the primary analysis in Fidelity was looking at cardiovascular events. Even though these were patients with diabetes and chronic kidney disease, the primary endpoint here was cardiovascular events. And so you can see a significant reduction in cardiovascular events, and on the lower right-hand part of the slide on the right, you can see a 22% reduction in heart failure events. So that, I think, again, a very robust set of findings for finerenone. Here's the kind of thought experiment. I just want to come back to the importance of UACR testing one more time just to try and crystallize the importance of this. So based on the Fidelity results, the investigators there, I think, did a really elegant modeling analysis. And so they took NHANES data. That's a national kind of representative data set from the US. And they said, hey, what's the number of patients that would fall into different ADA, KDIGO heat map categories just based on what we know about their EGFR and based on their UACR. And sure enough, you can see all the different, kind of cut points across EGFR on the bottom here, and then substratified by, is the UACR markedly elevated, greater than 300, or less than 300, so between 30 and 300 on the right-hand panel. And as you would expect, there's so many more patients, right, that will benefit from potentially be eligible for finerenone that have normal EGFRs, right? Just by virtue of the population. Yes, all of these patients benefit from finerenone, and we saw that in Fidelity. But just by sheer population size, there's so many more patients on the right-hand categories here that have an EGFR of 60 to 90 or greater than 90 relative to those that have CKD stage 4, 5, or 3B. On the left-hand part of this panel. But here's the really interesting part of this. Then they go back and they say, hey, let's do a simulation of how many events would actually be averted in these different populations. And so if you look, I sort of summarized it on the bottom of this figure. If there's 6.4 million estimated finerenone-eligible U.S. individuals on the basis of albuminuric CKD and type 2 diabetes. Remember, that's the population of the two trials that contribute to Fidelity. It's estimated that nearly 40,000 cardiovascular events could be averted right? If we use a nonsteroidal MRA in patients for whom it's been shown to be highly effective, you could prevent 40,000 cardiovascular events. But the next sentence is the most critical. Of those events, 2/3 would be in patients that you only would have found if you checked the UACR, right? Because all of these people that have an eGFR above 60, they wouldn't be eligible for finerenone because they would never be diagnosed as having CKD if you didn't do the UACR test. So that means of those 40,000 events, 2/3 of those, 25,000 plus, will be averted only when we do UACR tests, we diagnose them with CKD, and then implement a therapy like this. So I think the immediate action step is to heed the advice of virtually every professional society out there, from the Diabetes Association to KDIGO to the ESC to even the National Centers for Quality Assurance, the NCQA HEDIS measure, which is we should be screening for CKD all patients with type 2 diabetes annually. And to screen, we have to look at both eGFR and UACR. eGFR alone is insufficient to screen for CKD. And you make a CKD diagnosis if the eGFR is less than 60 or the UACR is above 30 milligrams per gram. I think that's a really important thing that we should all just agree on and start doing in our own clinical practices. I'm going to quickly touch on this. So Fine Arts HF, that was the recently released data at the European Society of Cardiology, looking at patients with an EF above 40%, randomized to finerenone versus placebo. Again, I'm going to go through this very quickly because I want to get to the last part of the presentation. And you can see about a 16% reduction in the primary endpoint. That's CV death, total heart failure events. And then if you look at CV death or first heart failure event, the point estimate was identical, 0.84, slightly more power there. And so the p-value gets a little bit lower. There's many more trials of finerenone to come, so I just wanted to put this on there if anyone's interested. They're doing a host of clinical trials in different EF cut point, different background therapy. I think very interesting. They're doing a clinical trial of SGLT2 inhibitor in combination with finerenone, versus placebo. So that'll be interesting to see kind of what happens there. The last area that I want to touch on is probably the most exciting. I think Dr. Hani already showed some of the data from the SELECT trial. I want to go through that a little bit with you here. So here's the overall study schema for SELECT. This is randomizing to semaglutide 2.4 milligrams once a week versus placebo. All the patients in this study have a history of atherosclerotic cardiovascular disease as well as obesity or overweight. They cannot, by virtue of the protocol, have diabetes, right? We already know from other trials that those patients benefit, right? We talked about that in the first section, and Neto obviously went through all of those data in a lot of detail, that we had learned that from prior studies. So here's the baseline characteristics. I don't think there's really anything specific to point out here, except to say what was the cardiovascular inclusion criteria. About 2/3 of the patients had a prior MI, 18% had a prior stroke, PAD. The eGFR was 82, and they don't even report the UACR in this study. So remember earlier I was sort of saying, man, even the way we do trials and the way that if we're serious about CKM, the way we do evidence generation, the way we think about designing and conducting clinical trials has to change too, to really deeply phenotype the patients and figure out where are they on the CKM syndrome. That wasn't even done in this study, and the eGFRs are normal, quote normal. But nonetheless, we'll sort of come back to that in a little bit. You can see the systolic blood pressures there, 130/80. pulse of 70. Here's the intermediate endpoints, so not even the CV outcomes, but let's just sort of spend a minute to go through the intermediate outcomes here. So you can see the A1C kind of effect, and these are all non-diabetic patients, but now 2/3 of the patients have an A1C of less than 5.7. That's great news. And that's among the people that had an elevation of more than 5.7 at baseline. And so I don't think of that as, quote, preventing diabetes, but it's a powerful effect nonetheless. What happened to body weight? About a 10% reduction in body weight with semaglutide. You can see the reductions in waist circumference, systolic blood pressure, diastolic blood pressure. I think Netta or Dr. Hani pointed out look at the reduction in high sensitivity CRP, 40% reduction in hsCRP with semaglutide, and then look at the bottom row, almost a 20% reduction in triglycerides. Right? That's just intermediate endpoints. Here's what happened to events. So in the upper left-hand corner, you can see the primary cardiovascular composite, 20% reduction. I think other speakers alluded to this too. We have talked and argued at every scientific meeting for hours and days about one antiplatelet versus another antiplatelet, right? For effect sizes that are smaller than this, right? On recurrent periprocedural MIs. This is a 20% reduction in hard events in patients that have atherosclerotic cardiovascular disease and obesity or overweight. I think you can see the heart failure composite in panel C, 18% relative reduction there. And then all-cause death, nominal hazard ratio, 0.81, and you can see the 95% confidence interval there. There's going to be a lot more to come. Sorry, this doesn't maybe reflect all that well, but the tirzepatide part of this story is going to be coming. There's going to be lots of trials, lots of presentations, and I think important data that will emerge. I think a couple of important things, the SURPASS CVOT, I think Netta was talking about that a little bit earlier. I think the interesting thing about that is dulaglutide it's an active comparator trial, right? I think that's a very important set of findings then to say, hey, let's compare tirzepatide to a GLP-1 receptor agonist for patients with a very similar kind of profile as to what was studied in SELECT. And then SURMOUNT, MMO, at the very top of this will be the last one to report out. That's very similar to what was done in SELECT. And so we'll get very complementary data for tirzepatide to what we got with semaglutide. I think the second to last slide here, which is just to say, this is another sort of modeling exercise. This was just published in Circulation, I think, in the last couple of weeks. And what these investigators tried to do, again, was trying to embrace the CKM framework. And so they said, hey, our phenotype that we're interested in looking at for this particular analysis, and you could imagine you could do this for other phenotypes and other overlapping, parts of the Venn diagram for different parts of CKM, but this was in patients with type 2 diabetes and albuminuria. And they said, imagine if we did sequential therapy titration for patients that have type 2 diabetes and albuminuria. That would include an SGLT2 inhibitor, a GLP-1 receptor agonist, a nonsteroidal MRA, and look at the effects of, this is a simulation, so there's never been a trial that has actually done triple therapy versus dual therapy versus monotherapy, and there likely never will be. But that's the information that your patients want, right? That's the information you want to be able to tell them. Sir, ma'am, for your diabetes and albuminuria, for your diabetes and CKD, if we use this particular combination of medicines, this is the benefit that's likely to accrue for all kinds of events, MACE, hospitalization for heart failure, CV death, CKD progression, all cause mortality. And so I only put this slide in to say we're all thirsty to get more evidence to guide decision-making, and I think we desperately want data like this to try and engage with our patients, to do real shared decision-making with real, what would be ideal is individualized estimates of benefit and risk. Again, this happens to be done for type 2 diabetes and albuminuria. Imagine doing this for a patient with diabetes and ASCVD. Well, if you added on an SGLT2 inhibitor with a GLP-1, maybe with other therapies as well that will come and emerge down the road, this is the benefit that's likely to accrue on a series of different kinds of endpoints. So I think really stay tuned. It's an incredibly exciting time, and I think we will get obviously more evidence to guide practice in this area. So my last slide, I think we're in the midst of a real paradigm shift. Timely identification of CKM syndrome and its management really taking center stage. I think it's really incredible to hear about the work that is happening here. You guys really were way out in front here in UAE on this front. We desperately need to adopt UACR testing as a complementary parameter to uncover patients with CKD that warrants intervention. I think that's not the job of any one group. That's not the job of one specialty versus another. It's everyone's job. We all take care of these patients. If we're serious about doing best for them, then I think we have to embrace CKM and really do the testing and do the screening. SGLT2 inhibitors and GLP-1 receptor agonists, very robust data to favorably impact patients with CKM from ASCVD, heart failure, and CKD, and obviously the guidelines have really endorsed them as powerful risk-reducing therapies. Non-steroidal MRAs appear to be effective at lowering CV risk. Patients with HFpEF, we saw that in fine arts, as well as CKD and type 2 diabetes. We saw that in Fidelity with additional evidence in HFrEF to come. And the use of GLP-1 receptor agonists in the management of obesity and atherosclerotic cardiovascular disease. The SELECT data that we talked about specifically and the others for tirzepatide and other therapies to come to reduce recurrent cardiovascular events presents yet another critical component of the management of CKM syndrome, though challenges in access and cost continue to arise. And so with that, I'll sort of close us out and thank you again for the invitation and opportunity.